Good evening, everyone.
Good evening, sir.
Hi. Guys, can you see my screen actually?
Yes, sir, it's visible, sir.
Good. Hmm. So do we have all the panelists? Anyone? So who is here? So hi, Roshni, are you are here, right?
Yes,
From
sir.
yeah. Hi. So do we have all other panelists, Dr. Ilavarsi and Dr. Kiran? Are they here?
Kiran sir is there. Sir will be joining in the panel. Just give us a 2 minutes, sir. All the people will be added to the panel.
Just find out. Hi.
Yes, sir.
So
Good evening, sir.
hi, Kiran. Hi. Peta, are you there? Hi, Rudra.
Good evening, sir.
Good evening. All good?
All good, sir. I think they're doing, Rosna is doing.
Okay. So, Roshni, I haven't met before, is it? We met Anita. So she's Roshni. She's also with me. Hi, Roshni. Good.
Glad to meet you today, sir. Thank you.
Same here, same. I think we will not delay much. We have around 50 people already. So I think we can start actually, right? So others can chip in and others can join. What do you suggest, Roshni? We should start, right? It's already 7 o'clock. Or we should wait for some more time?
We'll start, sir. We'll give a reminder call for the other people also. They'll be joining in between.
Fine. So let us go ahead because after that we have another talk also. So good evening, everyone. So can I share my slides now?
Yes, sir, please.
So this is visible, right?
Yes, sir. It's pretty visible.
So good evening, everyone, and welcome to another edition of Continuing Medical Education, jointly organized by the All India Institute of Medical Sciences, Department of Medical Oncology, in association with the International Association for Integrated Oncology. And this session has been sponsored by Dr. Reddy's Laboratory. We have been having previous sessions also on variety of topics with some eminent speakers from India and outside. And today we are going to discuss on a very commonly seen situation in oncology, that is anemia. And it would be inappropriate to say chemotherapy-induced anemia. Rather, it will be more appropriate to call it as cancer-associated anemia, because this is what we are going to talk about today. And I am Dr. Saurabh Kumar Mishra. I'm a associate professor in the Department of Medical Oncology Hematology at All India Institute of Medical Sciences, Bhubaneswar. And to be part of this panel. We have with us Dr. Ilavarasi. She was an assistant professor at AIIMS Bhubaneswar. Currently, she is based out of Pondicherry. We have Dr. Kiran. He is a medical oncology resident in the Department of Medical Oncology, AIIMS Bhubaneswar. We have Dr. Chandra Teja, who is a tutor in the Department of Medical Oncology. And we have Sheta, who is a oncology nursing. So basically, we have diverse people from variety of backgrounds. The reason being that the management of cancer-associated anemia is also diverse. You need a team of doctors and specialist nursing officers to take care of such patients. With this brief introduction, we now come to the incidence. It is not uncommon. Day in, day out, we would see so many cancer patients, and we would be seeing anemia or low hemoglobin in these cancer patients. And so at this point, I would like to ask Kiran. So I would request the panelists to switch on their video when they are replying. So Kiran, how common do you think is anemia in your clinical practice? How many, suppose we see 10 patients of cancer, how many would be having low hemoglobin? That means before the start of their treatment or during treatment or after treatment?
Uh, Sir, before starting chemotherapy, I can say out of 10 patients, somewhere around 4 to 5 out of 10 will have anemia. And once chemotherapy starts, like after 1 to 2 cycles, definitely it will increase, sir. Yeah, somewhere around 7 to 8 out of 10 patients will be having chemotherapy, especially with platinum agents or antimetabolites. The anemia will be more, sir.
So Teja, do you agree with Dr. Kiran? I mean, the incidence of cancer-associated anemia, it does increase starting before the patient has been on treatment, and then it increases during treatment. Would you agree to that?
Yes, sir, I agree with what Dr. Kiran has said.
Fine.
Mostly it is seen in gastric cancer and OBGYN cancers, where we give bone marrow suppressing agents like 5-fluorouracil, methotrexate, imaco regimens like that.
Fine. So you are telling there are multiple causes of anemia. One of them is chemotherapy-induced anemia. So when you give some chemotherapies which are genuinely causing marrow suppression, they would have more incidence of anemia. So what do you think, Kiran, are the causes of anemia in a cancer patient? I mean, we can divide it like cancer related.
Yes, sir.
And
Cancer related and treatment related also, sir.
yes, so you can describe some of the commonest causes which we see of the reasons for anemia in cancer patients.
So cancer related only, the disease per se, it is a chronic inflammatory disorder. So it will cause both absolute and functional iron deficiency. And certain cancers like gastric cancers, colorectal cancers, where bleeding per rectum or occult bleeding will be there. So it will also cause loss of blood. And certain cancers where hemolysis occurs, even that will cause. And along with that, apart from cancer per se, chemotherapy-induced anemia also is one of the major concerns, sir. Like mainly, as Dr. Teja was pointing out, bone marrow suppressive agents, antimetabolites, platinum agents, drugs like cyclophosphamide and gemcitabine. These are notoriously known to cause chemotherapy-induced anemia, sir.
Hi, Ella, we have you here. How are you?
Hi, sir. I'm fine. How are you?
Can you please switch on your video? We are really
Yeah,
raring to
I'm trying to do that. 1 minute.
Fine. So
It's not.
basically, no issues. So Ella, so
Sir,
in
I
your
will
practice,
leave and join. I'm not able to find. I'll leave and join. 1 minute.
yeah, fine, you join.
Yeah.
So basically, this is what we were discussing. The causes of anemia could be cancer related or treatment related. Also, there are a lot of nutritional anemias. So patients of
Yes.
cancer do have a lot of deficiency of common vitamins like vitamin B12, folate, because of decrease either intake or due to decreased reduced absorption, right? And also, as you said very well, that is functional deficiency also. So although reserves are very high for iron, they are not able to be utilized for synthesis of blood. So that is known as a functional deficiency due to the inflammation. So these are various causes of anemia. And as you see, the incidence is very high in some of the malignancies like breast because you use highly myelosuppressive chemotherapies. And you also see in leukemias very high, lung cancer, pemetrexed, GI, colorectal. So a lot of malignancies. So incidence is high. So this we have already discussed how common it is. So we have a grading of anemia. So how do you grade chemotherapy-induced anemia?
Sir, based on CTCA guidelines, usually grade 1, grade 2, grade 3, grade 4, wherein grade 4 will be usually life-threatening. Grade 1 will be around 10, around up to 10. Grade 2 will be around 8 to 9.9, and grade 3 will be less than 8, sir. 6.5 to 9.
This is known as CTCA, common toxicity criteria for adverse events. Whenever we are giving chemotherapy and our patients develop anemia, so there has been a grading of anemia. So in that, the grade 4 is something which is life-threatening. So patient has so much of anemia, it becomes life-threatening either due to heart failure or due to severe hypoxia, which is seen in these. Otherwise, it is grade 1, grade 2, and grade 3 anemia. Mostly we see grade 1, grade 2 anemias, but grade 3 anemias are also common in this setting. And variety of chemotherapy regimens, as we discussed, you can see in breast cancer, if you go for a triplet chemotherapy regimen, this is a TCH, the incidence of grade 3 anemia is around 1 in 10. If you have AC Texans, grade 3, 4.5, colorectal cancer, so grade 3, 2.9, 4.3, and then other regimens also. Meaning to say, as you go for more myelosuppressive regimens, you end up with having more anemia. The same also stands true for studies from India, where almost 50% of patients have cancer related or cancer associated anemia, with severe anemia in 6% of the patients. Now, what does anemia do to our patients? So, Teja, you can tell us. So, basically, a patient is there and he is anemic. So, how does your treatment decision change? What practical challenges you face when a patient in your clinic who is planned for anemia, planned for chemotherapy, lands up with you?
Generally, our chemotherapy patients present with dyspnea, giddiness, some hypotension. Most of them are weak. Their performance status is generally 2 or 3. We'll have to postpone our chemotherapy cycle for them. There will be dose reduction or there will be dose delay. If the grading of anemia is in a grade 3 or grade 4, we'll be proceeding with transfusions, blood transfusions. Generally, for grade 1 and grade 2, currently we are not taking any interventions or can I say any therapies for them. We encourage them to take a more balanced diet, more nutritious diet.
Right. So basically what I would say from his summarize is that suppose the anemia is severe, we would like to go for blood transfusion then and there. So 7 is the target which we set for our patients. And if the patient has some comorbidities like cardiac conditions and all, we would go around 8 to 9, around 8 for transfusion of blood. But for patients who are having otherwise low hemoglobin, that is grade 2 anemia, that is around within 7 to 10, usually we would work up them. It's not like we will just leave them. We will do certain workup to find out what is the cause of anemia in these patients. Because if this patient has an anemia in this cycle, it is quite likely, unless you go for some intervention, just go on giving chemotherapy, he may land up with severe anemia subsequently. So basically, with severe anemia, you go for some form of transfusion. because that would improve their fatigue, improve lethargy, improve dyspnea, improve their quality of life, improve their performance status, and you would be able to give the chemotherapy to this patient. So with all this, when the patient has anemia, all these factors come into play. They are more fatigued, they are lethargic, dyspneic, and we have to delay or reduce the dose of chemotherapy. Also, there is effect of anemia on the tumor per se, because tumor out. Hi, hi, Ila, how are you? Long time. And it's
How are
really
you, sir?
good. It's really good to see you.
Miss you all.
So basically, we were discussing, Ila, about the causes of
Yes, sir.
anemia.
I was able to hear you. Only thing is, I joined as an attendee, so that's why I was not able to switch on my
Fine,
audio.
fine.
Yes.
So, Ila, so basically, in your practice now, patients anemia, what would be the incidence? I mean, how common is anemia there? Here we, as you know, we used to have 60-70% of the
Yeah.
patients. How is it there?
Sir, almost similar, around 40 to 50%, we'll see grade 1, around 50% around grade 1 anemia. More than that, around 30 to 40%, we'll be seeing around grade 2 anemias. Around at least 15 to 20%, we would need some kind of an intervention before going for chemotherapy to correct the anemia.
Fine, fine, fine. So this is what is common across. And when you have a tumor hypoxia, it is a contributing factor for a tumor to respond poorly to chemotherapy, because when there is tumor hypoxia, the medications would not reach properly to the cancer cells, and it will ultimately lead to decreased or poor outcome with cancer chemotherapy. Now let us come to how do you evaluate anemia in patients undergoing chemotherapy. So we can take this from Ila. So how do you practice? What do you do, Ila, usually when you practice, when you such see? I mean, first of all, we can ask you at what level usually you start working up your patients, and how do you
Sir,
work?
in general, the cutoff which I would consider working is 8. When the patient presents with hemoglobin of less than 8, I would start my workup on OPD basis generally. Generally, it depends upon what type of tumor it is to assess whether it is loss versus nutritional. For example, if it's colorectal or anything to do with GI, my concern would be to assess whether there's an ongoing blood loss. In one aspect, we would be evaluating for nutritional deficiencies, especially iron deficiency and vitamin B12 deficiency. Out of which iron deficiency is more common. Gastrectomy deficiency to be more common based upon this. While on workup of iron deficiency, we found to have deficient iron, there I would like to further assess whether it is iron deficiency per se, or there is some utilization defect which we've seen in many of our advanced cancer patients. So based upon that, again, I would proceed my further evaluation with iron or erythropoietin and so on. In severe cases or in very symptomatic patients or in patients with comorbidity elderly, there we would prefer transfusion like you told before going for iron the evaluation. We wouldn't wait for the evaluation.
Fine. So basically, the NCCN recommends hemoglobin less than or equal to 11 or more than equal to 2 gram per deciliter below the baseline. So that is gender specific actually, to go for some evaluation. And when you go for evaluation, the common investigations are a complete blood count with a peripheral smear in which you see the morphology of the cells, hypochromic or normochromic, normocytic, microcytic, macrocytic. Accordingly, you see. And then, as she said, that evaluate the possible causes of anemia. First of all, you have to go for checking the reticulocyte count, the mean corpuscular volume. So the mean corpuscular volume, as you know, accordingly, we have the microcytic and macrocytic anemia. Iron deficiency is a microcytic and vitamin B12 is a macrocytic anemia. There can be dimorphic anemias also. Reticulocyte count, we go for corrected reticulocyte count for the levels of hemoglobin. We also consider for hemorrhage, as he was telling, when there is the hollow organ involvement like the colon or the urinary bladder. We think about hemolysis also. When we think of about hemolysis, like in patients with hemolytic anemia, like in CLL, we go for the Coombs test. If we think sepsis, we go for a DIC panel, indirect bilirubin, lactate dehydrogenase, which is elevated, nutritional, very common, iron deficiency, serum iron, ferritin, T, transferrin saturation has to be done. And if the nutritional deficiency due to B12 and folate, then you can go for other inherited anemias. Chronic kidney disease is very, very common in many of our patients, either due to the renal dysfunction is due to either chemotherapy or they have a chronic disease. So when you have to, therefore, you have to assess renal dysfunction also. Sometimes there is radiation when given to the pelvis and the marrow is exposed to the radiation. Therefore, radiation-induced myelosuppression, many of the hormonal dysfunction, which is very commonly missed, hypogonadism, prostate cancer patients, you are giving anti-androgen therapy and they have hypogonadism, adrenal dysfunction, that also causes anemia, hypothyroidism, finally anemia of chronic inflammation when the inflammatory markers like C-reactive protein and ESR. So this is a battery of tests. You need not do everything at the outset. You must have a clinical suspicion based on this MCV, based on this reticulocyte count, and accordingly, you can work up your patient. But these are some of the investigations which you should do, taking into consideration your clinical thing. Just give me a minute. Hello. Just give me a minute.
Hello, Shweta. Joshna.
Hello, ma'am. I have joined as a DM resident here.
Hi, Kiran. Hi.
Hi, ma'am. Hi,
I'm
ma'am.
just being with you. It was very close. Hi, Shweta. How are you?
No, ma'am. Am I visible, ma'am? Hello?
Yeah, you are.
Yes, ma'am.
You're visible
I'm
and
fine.
audible, Shweta.
Nice.
Sorry, guys. Sorry. So, Shweta is here. Fine. So we now saw what are the workup to be done for anemia. Is my slide not moving? Yeah, right. So this is how you go for iron studies. If at all you are doing, it has to be done in a fasting state. Remember that we have to correct the reticulocyte count for the degree of anemia. Gender specific hemoglobins are considered. Then if you have a normocytic normochromic anemia, there are a lot of causes. In cancer patients, you may not find a hypochromic, microcytic hypochromic anemia. Most of the time, you would find a normochromic normocytic anemia, and your further workup has to be done based on the reticulocyte response. If there is appropriate reticulocyte response, that means the marrow is functioning. So you have to think about hemolysis or bleeding. If you have inappropriate reticulocyte response, that means there is ineffective erythropoiesis. So one of the causes could be inflammation, or there could be early iron or vitamin B12 deficiency, or organ dysfunction like bone marrow, hypothyroidism, hypogonadism, renal dysfunction, or chronic liver disease. So these are all the differentials when you come across a normocytic normochromic anemia, which can be differentiated based on the reticulocyte response. Now coming to a case, 58-year-old man presenting with intermittent hematochezia, diagnosed with stage 4 adenocarcinoma colon, receiving chemotherapy. Hemoglobin is 9, which is low. Ferritin is 9 gram per ml, which is low. serum iron is 41, which is low. TIBC is 430. Transferrin saturation is 9%. So, Kiran, what is your diagnosis? How are you going to treat this patient?
Sir, in this patient, as we see, hemoglobin is low and ferritin, which is long-term iron stores, are low, along with transferrin saturation is low with elevated TIBC. So it will be a case of absolute iron deficiency anemia, sir. So in absolute iron deficiency, iron supplementation is recommended. Usually, parenteral iron is better than oral iron in view of absorption and all, and other compliance absorption. So parenteral iron is better choice here, sir.
Ila, that's what we do, right? I mean, in such patients, we are giving chemotherapy. We need iron to be replenished. So parenteral iron is something absolute, right?
Yes, sir.
Fine.
TIBC and saturation.
Yes. So this is an absolute iron deficiency defined by low serum iron, low serum ferritin, and very low serum transferrin saturation, making it absolute iron deficiency. We have to replenish the iron stores. So how will you treat? So as we say, parenteral iron. We discussed here about the absolute iron deficiency when the total body irons are very low. That could be due to blood loss, or that could be due to poor iron absorption or depletion of the iron stores. However, in cancer, chronic inflammation, chronic infections, there are certain cytokines which are released, which act on the liver to cause the release of hepcidin, which ultimately leads to blocks the iron absorption and also transferring the iron into the marrow, so ultimately leading to functional iron deficiency. You have the iron stores here, but iron is not being utilized for synthesis of hemoglobin. So that is known as a functional iron deficiency, which is seen in cancer, chronic inflammation, and chronic infection. This is the same thing which is going. So based on these, we now come to the variety of situations which we can see. We do the serum iron ferritin transferrin saturation on iron studies, and absolute iron deficiency is when you have ferritin less than 30 and transferrin saturation less than 20. Based just on these, we can know absolute iron deficiency. Here we usually go for consider IV or oral and IV depending on the situation. Functional iron deficiency when we will be when ferritin will be high, that means storage is there, so more than 300, but transferrin saturation is less than 50%. Possible functional is ferritin very high, transferrin less than 50. No iron deficiency when ferritin is more than 800 and also transferrin saturation is more than 50. So if you see such a situation, the benefit of iron supplementation will be there where there is absolute iron deficiency, or when there is functional iron deficiency with a transferrin saturation of less than 50%, where you have to go for iron supplementation. In all other situations, iron supplementation is probably not going to benefit. That means when you have a saturation of either more than 50%, or when you have a ferritin of more than 500, in these situations, iron is probably not, supplementation is not going to work. Here, what will work is just erythropoietin therapy, right? So this is very well defined here. As you can see, the serum based on the serum ferritin and transferrin saturation, the green ones are the one where there would be some benefit of supplementation with iron. What could be that? When there is absolute iron deficiency less than 30 nanogram per ml and a transferrin saturation less than 50, or when there is 300 to 500 ferritin and a transferrin saturation of 20%. Less all other situations, iron probably iron supplementation is not going to work, right? So the red ones are the one where you may just go for the erythropoietin stimulating agent. So what could be the situation? More than 50%, anywhere it is more than 50%, whether it is in the serum ferritin 330 to 500, serum ferritin 500 to 800, whenever there is 20 to 50%, 50% or more, you have to just go for erythropoietin stimulating agents, right? So in these, there is no role of iron supplementation. Why we don't supplement here? because patients with a baseline transferrin saturation less than 20% have a higher response to IV iron when given with an erythropoietin stimulating agent. Between 20 to 50%, there is less response. So usually we would avoid. Now, what are the modalities we have? Oral iron and parenteral iron. So ILA basically parenteral iron is more comfortable. So when which situation in cancer patient usually you would go for oral iron? Is there any specific situation? Or
Sir,
parenteral?
oral iron, again, offering oral iron would depend upon patient factors and the disease factor. When it deals with patient factor, I should be convinced whether the patient would tolerate oral iron, doesn't have much vomiting or symptoms, gastritis. And second, the complaints of the patient also comes into picture.
Very
Whether
important.
they are consistent with the iron and the speed with which I want the iron repletion, that also would come into picture. So oral iron, I would confine to patients who has grade 1 or grade 1 anemia, who are asymptomatic and are very compliant, and who does not have much GI related disturbance with iron. These are the patients where I would offer oral iron. When it comes to parenteral, yes, sir.
Parenteral mostly. So basically, as a thumb rule, what we use is that during therapy, if at all we are having an anemia, patient is already on chemotherapy, and on anemia, usually we would go for iron supplementation IV in this way, because we need a rapid correction, and that is what the studies have also shown. If you go for iron IV parenteral, there is rapid replenishment of the iron stores and rapidly anemia is corrected. Mostly the patient, those who are not on active therapy, like they are on follow-up, they have come for routine checkup, and we found that they are having anemia, not very symptomatic, as you said, grade 1, grade 2, and on follow-up, and patient doesn't have any issue, we can go for oral replacement of the therapy, right? So that is what we usually do in our clinic, right? So these are some of the practical considerations. Generally, once we go for the iron studies, we go for replenishment of the iron. We don't do routine study unless and until there are 3 to 4 weeks after administration, and we can again check at that point of time. When would you consider repeating the iron studies? When the MCV declines, hyperchromic RBCs are seen on the peripheral smear, even after replenishment, you can go for peripheral smear study, again repeating iron studies. And when iron anemia does not respond to iron supplementation 4 to 6 weeks after administration of the intended dose, then also you should repeat the iron studies to see whether we have appropriately replenished or not. Now, coming to the common adverse events. So, Kiran, what do you see routinely in your practice? How many patients of toxicities have you seen?
So for IV, oh sorry.
Yeah, please, first, please tell us.
So for IV ions, we've been using carboxy maltose for ferricarboxy maltose generally in our practice, and I've seen less than 1%, sir. Like
Right.
very less infusion reaction.
Completely agree.
Yeah.
Shweta, so you are delivering the iron injections. How common is any form of reaction? Let us say immediate reaction. And what is the common iron we are giving here in our clinic, iron formulation of IV?
सर हेलो गुड इवनिंग एवरीवन. एक्चुअली सर हमारा सेटअप में हम लोग ज्यादातर कार्बोक्सी माल्टोस देते हैं, बट आयरन सुक्रोज भी कभी कभी हम लोग देते हैं इफ इट इज नॉट अवेलेबल इन आवर सेटअप और इन आवर इंस्टीट्यूट. बट ज्यादातर रिएक्शन जो आयरन सुक्रोज के साथ हम लोगों ने देखा है, मेनली पेशेंट शिवरिंग के साथ प्रेजेंट होता है, चेस्ट पेन होता है, चेस्ट टाइटनेस होता है, तब हम लोग पेशेंट का इन्फ्यूजन बंद करते हैं. तब हम लोग सोचते हैं कि आयरन से रिएक्शन हुआ है, बट अभी तो कम है, इन्फ्यूजन बहुत कम हो गए हैं.
तो कितना होगा आयरन सुक्रोज में जितना भी दिया है, हाउ मच आउट ऑफ 10 हाउ मेनी पेशेंट्स वुड हैव हैड?
सर आयरन सुक्रोज में तो हुआ है, जब मतलब इनिशियली जैसे पेशेंट को अगर कभी नहीं मिला होता आयरन, तब रिएक्शन हुआ है. जो स्टार्टिंग में सर माइनर माइल्ड इन्फ्यूजन रिएक्शन भी हुआ है, शायद रैश होना या पेशेंट को थोड़ा डिजीनेस या डिस्कम्फर्ट फील होने से हम लोग पेशेंट को थोड़ा टाइम डिसकंटिन्यू करते हैं इन्फ्यूजन, उसके बाद थोड़ा स्टेबल होने के बाद वाइटल्स चेक करके फिर से प्रोसीड करते हैं विद द इन्फ्यूजन.
So what she is saying is that with previous iron infusions which were available, iron dextran, the iron sucrose, there was some incidence of infusion reactions, adverse events. But with the current use of ferric carboxymaltose, the hypertension, nausea, vomiting, diarrhea, pain, abdomen, dyspnea, pruritus, all these are less, right? So this is the recommended doses. We can just focus on the ferric carboxymaltose. Here, as you can very well see, there is test dose at, so basically here we do not go for any pre-medications in ferric carboxymaltose. If you see the recommendation, routinely we don't go for any pre-medications, and the dose is usually 750 milligram when in a patient more than 50 kg, and repeat the dose once at least 7 days later. Total treatment dose is around 1500 mg, right? That is what we did. So pre-medications are not routinely used. And unless there is a history of allergy to more than one drug, or allergic diathesis, or an asthma, or a history of inflammatory arthritis, and wherein both parenteral and oral iron have been shown to exacerbate symptoms, if you have such history, you may go for pre-medication with hydrocortisone or Avil. Otherwise, routinely we don't go for any iron pre-medication. These are all the precautions or procedures, standard procedures for iron injection. And this is how you calculate the iron dose, routine dose. This is just simplified scheme. And iron can be, FCM can be given as a bolus over 10 minutes, or you can go for also IV infusion when you combine it with 250 ml of sterile 0.9% sodium chloride and infuse it over 15 minutes. This is how we usually give. Do not give IM, intramuscular or subcutaneous use, right? Now we come to the iron and erythropoietin stimulating agents. So we have an anemia and we want to go for improvement in anemia. We can combine this iron along with erythropoietin stimulating agents. We saw certain situations where iron injections or iron supplementation has to be given, like when there is absolute iron deficiency or erythropoietin is low with transferrin saturation less than 20%. In such situations, you must go for iron supplementation. Unless you go for iron supplementation, if you just go for erythropoietin stimulating agent, that will cause further iron deficiency, because erythropoietin stimulating agents will use the existing iron for synthesis of hemoglobin. So if you don't have an iron replacement or iron source which is there inside the body, erythropoietin stimulating agents will be ineffective. Therefore, it is recommended when you have a deficiency of iron, you correct the iron and then go for erythropoietin stimulating agents, right? So coming to the setting for transfusions, when are the setting when the patient needs transfusion? So Teja, can you tell us which are the patients in your practice when they need transfusion?
So, generally patients who are having the hemoglobin less than 7 or less than 8 hemoglobin or they're mostly symptomatic, feeling dyspnea, performance score 3. For them, we will advise transfusions.
Fine. So certain patients, if they are also having hemoglobin more than 7, they would need transfusion as per the guidelines, and those would be like cardiac disease, COPD, cerebrovascular accident disease. All these patients will need hemoglobin transfusion at a much at a threshold of around 8 or more than 8. We would like to give this patient. Also, very symptomatic patients due to hemoglobin low, there is sustained tachycardia, tachypnea, chest pain, dyspnea, lightheadedness, severe fatigue, syncope. All these patients, when they come to you with the clinic, even with a low hemoglobin not as low as 7, above 7 also, we can go for blood transfusion if you are finding patients in this setting, right? So now we'll come to when do you consider using erythropoietin stimulating agents, what are the type, dose, frequency, threshold, hemoglobin target, when to use, and toxicity. So we'll quickly go over it. Basically, simple. Remember, we don't use erythropoietin stimulating agents left and right. There are certain indications. Now, these drugs, when we are using it, we have to be very specific. We don't use it anywhere outside the specific recommendation, that is the patient undergoing palliative treatment. That means the patient is undergoing some active form of treatment, either chemotherapy, immunotherapy, or whatever. And it is a palliative setting. That means it's not a curative setting. That is the only setting where we use erythropoietin stimulating agents, right? So all other patients, we have to think before we use erythropoietin stimulating agents. As you can see here in the lower panel, patients with cancer not receiving therapy, patients receiving non-myelosuppressive therapy, patients receiving myelosuppressive therapy with curative intent like Hodgkin's, non-Hodgkin's, testiculars, and small cell, breast cancer, wherever you are having a curative intent of treatment, you are having anemia, we don't use erythropoietin stimulating agents in this setting. You must remember this. The only specific indication for erythropoietin stimulating agents is when the patient is getting active therapy for palliative treatment, right? And when to start treatment for such patients, usually the patient should be offered erythropoietin stimulating therapy when the hemoglobin is less than 10 gram per deciliter and target to less than 12 gram per deciliter. So so you start at around less than 10, and you can go maximum up to 12 gram per deciliter. Don't overcorrect beyond that, right? And what are the commonly used drugs which you have? Darbepoetin alpha is what we routinely use, has the maximum data in cancer. Erythropoietin alpha does not have that great data in cancer. Darbepoetin alpha comes at multiple doses. 500 microgram is what we use 3-weekly subcutaneous formulation. Some data to show that 500 and 300 have similar outcomes. Also, 200 microgram of darbepoetin is available. Usually, we use darbepoetin 500 microgram subcutaneous every 3-weekly in our patient. Let us come to the practical consideration. Why we are so super selective about giving erythropoietin stimulating agents? Because as you can see, there are certain studies, some ambiguity is there to say that there is a possible decreased survival in patients who are getting erythropoietin stimulating agents when you go for correction more than 12. That's why I said keep it less than 12 and outside the duration of chemotherapy. So whenever the patient is getting a palliative chemotherapy, that means initiation of therapy to up to 6 weeks. During that period, if you go beyond, there may be possible decreased survival due to cancer. Also, there is some data to say that metastatic breast cancer, small cell lung cancer, probably they have reduced survival due to erythropoietin. So these are some of the situations even in palliative setting probably we would avoid. Then there is the risk of thrombosis. So there is definitely a risk of thrombosis. Absolute increase, as you can see, around 3%. When there is non-users, 5% risk of thrombosis. With use of erythropoietin, 7.5%. And if you have certain risk factors of thromboembolism, like hypercoagulability, where cancer is already a hypercoagulable state, and pre-chemotherapy platelets are high, hypertension, and then certain factors, then the risk of thrombosis. Therefore, we are very selective in which patients we are going to use erythropoietin stimulating agents, right? So we'll come to the concluding slides here. So it is challenging to treat anemia in cancer patients, but we must treat such patients. Hemoglobin less than 7 to 8 should be treated with blood transfusion. Even if there are certain indications for blood transfusion with a higher hemoglobin, like acute situation, we can give blood transfusion. Iron correction has to be done when there is absolute iron deficiency, that is erythropoietin, the ferritin is less than 30 and transferrin less than 20. In functional iron deficiency with a transferrin saturation less than 20 and erythropoietin of 30 to 500, we may go for iron supplementation. There is no benefit of iron supplementation when the when the ferritin is very high and transferrin saturation is more than 50%. Erythropoietin stimulating agents are specifically indicated when we are using chemotherapy in the palliative setting and during the course of chemotherapy. And we should avoid these use other than these indications because there is a risk of toxicity. That's all from us. Thank you. I would thank all my participants and panelists for their beautiful insights, and thanks all. So organizers, is there any question for us, or we can go to the next section? We have the next speaker with us, is it?
Yeah, so like, and we have a question for that also, like from the
Fine,
participants
fine.
end.
So do you
Is
take
there
the
any-
question now?
Yes, sir.
Okay, so yeah. So Ila, there is a question. Is there any study on darbepoetin for curative setting?
Sorry, I couldn't hear your question, sir.
So is there any study for darbepoetin or erythropoietin stimulating in the curative setting?
Sir, which showed decrease in survival. There were early studies which
Okay.
studied erythropoietin and later darbepoetin, but then there were mixed results. Both in meta-analysis also,
Yes.
it didn't show much significance. There were
Fine.
many smaller data which showed some positive and some negative survival data.
So basically what she is saying is that there is some data to say that probably there are studies to say that darbepoetin and use in the curative setting is not recommended because of the deleterious thing in the
Side
survival,
effect.
right? Side effect and all. So that's why we limit our use to the palliative setting, right? So alternative to darbepoetin, as I said, in cancer, there is maximum data for darbepoetin. EPO, we have the epoetin alpha. It is mainly indicated with renal conditions. Of course, we have epoetin also. There is a trial which compared head to head between erythropoietin and epoetin alpha and darbepoetin and didn't find any difference between the two. So with the maximum data and studies on darbepoetin with darbepoetin in cancer patients, we are more comfortable using darbepoetin rather than epoetin. So I think that is all from here. So we have the subsequent speaker, is it with us?
Yeah, I have joined.
Hi,
Good
hi, Dr. Arnab.
Good evening.
How are you?
I'm fine.
We first thought that probably you would give a lovely talk and then after that we will be doing the panel. But
Yeah,
because
I'm extremely sorry. I got very late to come home from the OPD. So I think without further delay, after this wonderful
please go ahead.
discussion, we can start the topic. So thank you very much to the DRL team and the organizer for giving me this opportunity. So I will share the slides. I suppose it is visible and am I audible?
Absolutely.
Okay.
Yes, sir.
Thank you. So this is a slide presentation and it has been provided by the DRL team. So the topic is optimal use of erythropoietin stimulating agents in management of chemotherapy-induced anemia. So before that, coming to a little bit of mechanism, how the regulation happens in anemia of chronic disease. So, in tumors. So in the cancer, there is macrophage activation followed by activation of the pro-inflammatory cytokines like interleukin-6, which ultimately acts on the liver and expresses more hepcidin. And there is also decreased expression of the HIF and followed by decreased erythropoietin. So both of them causes the functional iron deficiency as well as decreased erythropoiesis, and thereby it causes the cancer-related anemia. So we know that erythropoietin is essential for terminal maturation of the erythrocytes. Erythropoietin rescues neocytes from apoptosis, and it helps to sustain RBC proliferation and differentiation. So there are a few trials which have established its role. So it has shown that the trials have compared actually darbepoetin versus epoetin, darbepoetin versus control, epoetin versus control, and epoetin or darbepoetin versus control. So this we can segregate like this. And if we come to a nutshell, so it ultimately causes increase in the hematologic response and decreases the transfusion risk. So considering all erythropoietin stimulating agents trials together, the pooled effect indicate that these agents improve the hemoglobin level. Pooled relative risk was 3.4 and result in fewer transfusion with pooled relative risk 0.58. Regarding the quality of life, health-related quality of life meta-analysis. So treating to high or optimal target hemoglobin level, that is more than 12, is accompanied by improved health-related quality of life score, like fatigue score. And any clinical significance of improvement is likely to be small. Overall strength of evidence is low. So there are also meta-analyses regarding overall survival. So there are few trials which have shown that it causes decrease in the OS, whereas there is some other trials which have shown, sorry, not trials, the meta-analysis has shown there is no decrease in the OS. What about the ESMO guidelines? So overall, there is currently no clinical evidence, neither single studies or nor meta-analysis indicating an effect of ESA on stimulating disease progression or relapse when used within level and following recommendations for treatment of CIA. So how judiciously you can use? So we have guidelines from the ESMO as well as from the ASCO-ASH guideline. So as per the ESMO, the ESA therapy is recommended in patients with symptomatic anemia who receive chemotherapy or combined chemo radiation and present with a hemoglobin level less than 10, as well as patients with asymptomatic anemia who receive chemotherapy with hemoglobin level less than 8. And target hemoglobin as per ESMO is 12 without RBC transfusion. For ASCO, the ESS may be offered to patients with chemotherapy-associated anemia whose cancer treatment is not curative and whose hemoglobin level declined to less than 10. Hemoglobin may be increased to lowest concentration needed to avoid or reduce the need for RBC transfusion, which may, however, vary to patient and the clinical condition. So there are different erythropoietin stimulating agents we already discussed, like erythropoietin, darbepoetin. And this is the target hemoglobin as per NCCN, it is 11. For URTC, 9 to 11, the optimal range. For ASCO, it is 10. And for ESMO, the target level is 12 without RBC transfusion. So what is the role of PRBC transfusion? So most of the cases, the level or the cutoff we take is 7 or 7.5. And these are extremely essential, especially for them who are hypovolemic or refractory to fluid resuscitation, like emergency condition. And when we need immediate correction, that is symptomatic anemia, and when we require a rapid correction of the hemoglobin. So with blood transfusion, there are different hazards, like allogenic blood transfusion may cause thrombotic as well as inflammatory response. A Cochrane review by Preston et al. On blood transfusion has shown a significant increase of hemoglobin level and subjective improvement of the symptomatic response rate. Patient survival varied greatly, and the review concluded that high-quality studies are warranted to establish the risk and effectiveness of blood transfusion in advanced cancer patients and to determine patients who are candidate to obtain a benefit. This is a retrospective study of nearly 2,600 patients. So it has what was the intention? So it was an analysis of the venous thromboembolism trend in chemotherapy-induced anemia, RBC transfusion versus ESA. And it has shown that nearly 25% patient developed a venous thromboembolism within 90-day period. The venous thromboembolism risk following RBC transfusion was more than twice the risk following ESA administration. And statistically significant increase in venous thromboembolism following RBC transfusion in patients with the colorectal cancer, hematologic cancer, and cancer of the head and neck. So we can draw a conclusion as per the NCCN, ASCO, and ESMO guidelines. Recommend use of ESA in chemotherapy-induced anemia. Indication should be in advanced malignancy who receiving the palliative myelosuppressive therapy. Other treatable causes of anemia should be corrected beforehand, because only the growth factor won't happen if there are other deficiencies. Discussing all risks, especially thrombosis and other pros and cons of ESA as well as for the RBC transfusion is essential. And epoetin and darbepoetin have almost similar efficacy, but darbepoetin is convenient to use and it's preferred by most of the clinicians. Now coming to the role of darbepoetin in NSCLC. So this was a phase 3 study, a RCT, non-inferiority design of long-term safety and efficacy of darbepoetin alpha for chemotherapy-induced anemia in patient with advanced NSCLC. So nearly 2,156 patients were included with 2:1 randomization of darbepoetin versus placebo. The patients were advanced NSCLC who received at least one line of previous prior lines of chemotherapy, and with hemoglobin level less up to 11 were eligible. The primary endpoint was OS. So regarding OS, darbepoetin alpha has showed a non-inferiority to placebo for OS. The upper confidence limit was 1.01, which was less than the pre-specified non-inferiority margin of 1.15. Regarding PFS, it again shows non-inferiority to placebo or PFS, because here also the upper confidence limit was 1.01 and the pre-specified limit was 1.15. Regarding objective response rate, so 36.4% versus 32.6%. However, it was not statistically different. So the superiority in reducing the incidence of RBC transfusion or hemoglobin less than or equal to 8 gram per deciliter from week 5 to end of efficacy treatment period. Here we can see that darbepoetin alpha had a better outcome. Regarding adverse events, so grade 3 or more adverse events are actually similar with darbepoetin alpha versus placebo. And if we consider other side effects, though there was also hardly any difference. And regarding thromboembolic events, so here we can see nearly 2.8% for darbepoetin alpha versus 2.3%. So there is hardly any difference. So I think we have come to the conclusion slide. Darbepoetin alpha with a dose of 12 milligram per deciliter, 12 gram per deciliter, hemoglobin ceiling was non-inferior to placebo for OS and PFS, and it significantly reduced the odds of transfusion or hemoglobin less than or equal to 8 in anemic patients with NSCLC receiving myelosuppressive chemotherapy. Safety findings were consistent with the known safety profile of darbepoetin alpha. In light of the results of this study, it can be considered for patients with advanced NSCLC and anemia who are getting the chemotherapy. So with these things, I am concluding here, and I'm very happy if there are any questions from the floor. So thank you, and over to the organizer.
Thank you, Arnav. That was nice, and you have finished well in time. So just tell us, in your clinical practice, when do you use your erythropoietin stimulating agents? I mean, you can say us at what hemoglobin levels you usually use, and also what is the formulation which you usually use, and how do you assess the response to these erythropoietin stimulating agents?
So, sir, normally whenever I start a treatment, so first of all, I do it in the palliative setting only. So whenever I get an opportunity, I try to see what is the hemoglobin level and the vitamin B12 folate level whenever it's possible. But however, it is not always possible. So we often check with the MCV level. And if the baseline the levels are low, I try to give the transfusion because there is a need for the palliative patients because for starting the treatment, because often the response rate is very much important. So with the starting, I know that it is often difficult after if you do the blood transfusion and the correction, the levels or this thing. But roughly, we start the treatment and then see how the patient behaves with the standard dose of chemotherapy, or maybe 80% or 75% dose. If the patient is not maintaining the hemoglobin level and MCV is high, so then I will try to give the darbepoetin. Majority of the time I use darbepoetin. So I use 100 microgram, 200 microgram, as well as 500 microgram, depending upon different condition. And there is no it interchangeably we can use, like it is 500 or 200 or 100. There is no actually logic which cases which one to select. But whenever I want a profound response, I try with the 500 microgram. And then I see how the patient behaves and what is the hemoglobin level in next 1 to 2 times of chemotherapy. Maybe the patient is getting 3 weekly chemotherapy, next 2 cycles I will see. If there is still it is not increasing, then I will again try to optimize some dose. And then after 2 cycles also, if not responding, then sometimes I repeat again with the rechallenge again with another dose of darbepoetin. So because every time it is not possible to assess the level of this one, and most of the times the patient will require associated iron transfusion also. So we have to check the percentage transfer in saturation, what it is, if it's less than 30% or less than 20% specifically. So actually we see a lot of things together, and judiciously we'll try to use.
So suppose a patient has been started on darbepoetin and his hemoglobin was around 9, and we would, let us say it was 8, and we would expect after the darbepoetin that probably it would increase to 9 or something, and then you would give another dose. But by the time the patient comes to you, his hemoglobin is now 7. So probably this patient would now need a blood transfusion. So when this patient now needs a blood transfusion, so how do you sequence the blood transfusion and the darbepoetin? I mean, would you first give the blood transfusion and then subsequently the darbepoetin, or how you? It's a very situation which we see. I mean, we are giving darbepoetin, still the patient is having low hemoglobin, 1 or 2 doses. So how do you manage such situation?
So, sir, when the patient requests, so first of all, I don't transfuse if the hemoglobin is more than 8. I normally transfuse if it is less than 7, or sometimes 8 also I can take, but not more than that. And now when there is a requirement of this dual use, I don't think that there is any rule of which one to give first. So what I do, if the chemotherapy is pending, so I will give the blood transfusion and chemotherapy maybe 1-2 days. Either I can prepone or postpone 1-2 days, and in between we can give the darbepoetin. So the patients can take in the home also, because it is subcutaneous administration. So my first priority is to treat as well as give if there is definite indications of blood transfusion to give, and then add on top of that the ESS.
Right, so that's very appropriate. So you give the blood transfusion and then you go for the chemotherapy, and then patient can take the darbepoetin anytime, right? That's what is good. So I think that has been a very interesting session. So I would like to thank Dr. Arnab, Dr. Ila, Dr. Kiran, Chandra, and Sweta. And I would like to thank DRL and the International Association of Oncology for organizing this CME. I would like to thank all the participants who have been here and who have really been there for last 1.5 hours. They have interacted and they have asked their questions. So we would again come back in a couple of days with another webinar, interesting webinar on lung cancer in a couple of days with recent updates. And with that, thank you, everyone.
Thank you, sir.
Thank you, sir.
Thank you all for joining, and all the participants will receive the certificate in a week to your registered mail IDs. Thank you. All the registered participants will receive certificate along with the recordings within a week. Thank you.